Childhood Mental Health Training and Technical Assistance Center is funded by the New York City Department of Health and Mental Hygiene. And TCHAC is a partnership between the New York Center for Child Development and the McSilver Institute on Poverty, Policy, and Research. New York Center for Child Development has been a major provider of early childhood mental health services in New York, with expertise in informing policy and supporting the field of early childhood mental health, both through training and direct practice. The NYU McSilver Institute for Poverty, Policy, and Research houses PREPP and the Community and Managed Care Technical Assistance Centers, otherwise known as CTAC and MTAC, which offer clinic, business, and system transformation support statewide to all behavioral health providers. TTAC is tasked with building the capacity and competencies of mental health and early childhood professionals through ongoing training and technical assistance. And if we go to the next slide, you'll see a screenshot of our website. And I just want to let people know that if you go there, you will see an archive of all of our trainings that we've done, and you'll get both recordings as well as the PowerPoints, as well as other resources. And if we go to the next slide, I'm also really thrilled to let people know that we've launched 2 early childhood mental health learning modules, which are now live. The first one focuses on the impact of early childhood adversity, and the second is nurturing resilience, supporting infant and early childhood mental health. And both offer CEUs and our wonderful introduction to the whole field of infant and early childhood mental health. So it is now my pleasure to introduce Dr. Elizabeth Warner, our presenter today. She is Assistant Professor of Behavioral Medicine in the Departments of Obstetrics and Gynecology and Psychiatry at Columbia University Irving Medical Center. She's also the Director of Clinical Intervention Research in the Perinatal Pathways Lab. Dr. Warner is a co-developer of the PREPP program, which we'll hear about today, a psychotherapy intervention aimed at preventing postpartum depression. She is also the Associate Director of Women's Mental Health at OBGYN, through which she also provides clinical care. Dr. Warner specializes in the treatment of mood disorders and stress management, particularly working with women during the perinatal period, during struggles with fertility, and during assisted reproductive interventions. Dr. Warner is a co-investigator on several projects funded by the NIH and has published papers on a variety of topics in the fields of perinatal psychiatry and developmental psychobiology. She was selected as an NIH CHIPS Fellow, Child Intervention, Prevention, and Services, and as a New York State Office of Mental Health Policy Scholar. So it's now my privilege to turn it over to Dr. Warner.
Hi, so happy to be here today with all of you to talk about postpartum depression and specifically preventing postpartum depression. So before we get started, I thought we'd go over some key terms because there's a lot of words that we hear a lot that are floating around, and it's great to have some clear definitions before we get going. So postpartum depression, often referred to as PPD, is depression that's occurring during the postpartum period. Then what we'll see is perinatal depression, and perinatal refers to things that are happening during pregnancy as well as after birth. So this could be referred to a depression that started during pregnancy and continued until the postpartum period. It could also refer to a depression during pregnancy or in the postpartum period. And then we have perinatal mood and anxiety disorders. Again, this refers to mood and anxiety disorders that occur during pregnancy and or after birth. And it's often referred to as PMADs. So you'll see PMADs in a lot of places, and that what we're really talking about is symptoms of depression, anxiety, and people who qualify for these specific disorders during the perinatal period. All right, so with that out of the way, let's get a bit of an overview of what we're going to be talking about today. So we're going to be talking about postpartum depression and PMADs. We're going to review the symptoms. We're going to talk specifically about risk factors for PMADs. We're going to be talking about the long-lasting effects of PMADs, and we're also going to be talking about access to treatment. If you hold one moment, I think I'm getting a little sound effect in the background here, and I want to be able to stop that. So give me one quick moment to do that. Thanks for your patience with that. Then we're going to be talking a bit about PMADs and access to treatment. And we're going to talk about what a missed opportunity we have for providing perinatal mental health care. Then we'll be focusing really on preventive interventions. And we'll briefly review 2 interventions, Mothers and Babies and the ROSE program. And then we're really going to have an in-depth look at the PREPP program, which is an intervention developed by my colleague, Catherine Monk, and myself. And then we'll talk a little bit about conclusions and takeaways from this talk. And of course, lots of time at the end for questions. So postpartum depression in the United States is the most common complication of childbearing. 20% of postpartum parents will experience an episode of major or minor depression within the first 3 months postpartum. I'd like to clarify a bit about the difference between the baby blues and postpartum depression. Most people who give birth experience the baby blues. The baby blues describes the irritability, sadness, crying spells, or frustration that many parents experience within the first few days and up to 2 weeks after giving birth. Now, postpartum depression is similar to the baby blues, but a bit different, specifically because the symptoms are more persistent and can include sleep difficulties, changes in appetite, and anxiety and panic. Postpartum depression can also affect the ability to bond with the baby. Here I have some symptoms of postpartum depression that are described on the Postpartum Support International website, a great organization, and I'll talk a bit more about them later. So symptoms of postpartum depression: feeling angry, both anger at yourself, anger at other people, even anger at the baby, feeling very sad, irritability, guilt, a lack of interest in the baby, changes in eating and sleeping habits, meaning either eating a lot more, sleeping a lot more, or really having any difficulty getting any sleep. And this is not just related to feeding the baby and waking up with the baby, but even when there's an opportunity to sleep, it's hard for the person with postpartum depression to sleep. Also, perhaps not feeling like you want to eat anything at all. They can describe trouble concentrating, thoughts of hopelessness, and sometimes even thoughts of harming the baby or harming themselves. There have been a lot of risk factors that have been described for postpartum depression. And what I'd like to do is really focus on the first 2 on this list, because these are really the most predictive risk factors for postpartum depression. So people who have these first 2 risk factors are more likely really to experience postpartum depression. So the first is having depressive and anxiety symptoms during pregnancy. The second one is, even before you were pregnant, having a history of mood disorders. So if you are working with a patient like this, you really want to be thoughtful about what the postpartum period looks like for them, and really organizing and getting resources together, because there is a greater likelihood that this person may suffer from a postpartum depression. In addition to those risk factors, there are other risk factors that have been well described. One is a lot of postpartum stress or stressful life events that happen during the postpartum period, a lack of social support, having a pregnancy that is complicated, and having a lot of medical issues during that pregnancy, or having a lot of obstetric risk factors that you're trying to manage during pregnancy. The next is a pregnancy with more than one fetus, being at a young age during pregnancy. So teen pregnancy comes to mind, or someone who is in very early adulthood. Low socioeconomic status and having financial strain is another risk factor for postpartum depression. Having childcare stress or uncertainty about childcare, or childcare that you don't feel confident in. Relationship conflict. Co-parenting can be extremely tough during this period, and constant conflict with your co-parent can make a person more likely to suffer from postpartum depression. Having an unplanned or unwanted pregnancy. And then the last is infant temperament. And specifically what we're referring to here is babies that perhaps cry and fuss more than is average, or babies that we have a difficult time with sleep. These can also make the birthing parent much more likely to suffer from postpartum depression. So Postpartum depression affects not just the birthing parent, but everybody in the family. So for the birthing parent, there are long-term psychological consequences with greater chances of people having anxiety and depression later on. The birthing parent's also more likely to have relationship difficulties and report lower levels of social support when compared to non-depressed mothers. People who suffer from postpartum depression are more likely to experience suicidal ideation. They're also much more likely to have occupational challenges. If you have postpartum depression, it's much harder to return to work. It's much harder to function at work if you're able to return to work. And this can really set up longer-term occupational problems. And people who have suffered with postpartum depression are more likely to report a lower overall quality of life. Postpartum depression also has effects on the parent-infant dyad, not surprisingly. If the parent isn't doing well, then the dyad is certainly going to be affected. So there can be challenges in the general ability to care for the new baby. There can be a really profound effect on parental responsiveness, and of course, that has an effect on the infant. This can lead to less positive parent-baby interactions, and the quality of the bonding and attachment can be greatly affected. And this is not just in the moment as it's happening while the depression's occurring, but there can be a lasting change in terms of the quality of the attachment between the parent and the infant. So not surprisingly, we know that PMADs and postpartum depression specifically has an effect on the birthing parent, their partner, and the dyad. So not surprisingly, it has an effect on child development. And studies, so many, more than we could list on one or even 20 slides, have consistently demonstrated the deleterious effects of PMADs on child development, including cognitive development. And this is starting at a young age, but continuing through later childhood, bonding and attachment, which we referenced a bit earlier, and social emotional well-being. These associations also have been implicated in a broad range of child outcomes, including lower IQ scores in later childhood, poorer academic performance, and increased susceptibility to child and adolescent psychopathology. However, despite these long-lasting effects of postpartum depression, there is limited access to treatment. And the reason for this is that we, in our current systems, we have a lot of barriers to treatment. And this doesn't just apply to care for perinatal mood disorders. It applies to, I think, mental illness in general, but specifically, I think it's even more challenging to get access to care for perinatal mood disorders. So the most frequently cited variable hindering mental health treatment is the cost of it, or finding a provider that matches your insurance. There's also a lack of provider knowledge on postpartum depression and postpartum depression treatment, meaning that even if you can find a provider who accepts your insurance and has room in their practice to see you, or a clinic that has room to see you, finding a provider that actually has education and training in postpartum depression is more rare. People also cite time as a big challenge, and oftentimes mental health care appointments are they're really uncoordinated with OB care. So people are going to a lot of extra doctor's appointments, and it's hard to go to a whole other clinic or a whole other setting to be able to get professional help for perinatal depression. In addition to that, there's a lot of stigma about endorsing distress in the context of childbearing. There is this idea, and I think we're beginning to sort of challenge this idea, but that this should universally be a time you're pregnant, you should be happy about it, you have a baby, you should feel happy about it, and you shouldn't be feeling distressed or stressed or depressed during this period. And it can be something that people can feel quite ashamed of if they're experiencing this in the postpartum. There's also just in general stigma associated with receiving mental health care services in many communities. And then another barrier to treatment is medication, and many people view getting mental health care primarily as perhaps getting psychotropic medication, and there can be a disinclination for people to take these medications while pregnant or while breastfeeding. There have been many recent calls to action to try to change this. So there have been calls to action about the prevention of postpartum depression, about doing more screening, and about ways to really increase the access to care. Here on this slide, I have some organizations that have been really successful in improving accessibility. And the first is MCPOP for Moms, which has been spearheaded by Dr. Nancy Byatt. This is in Massachusetts. And it offers providers with by providers, I mean obstetric providers. So people are coming in for their OBGYN visits, and oftentimes in places where there aren't any perinatal psychiatrists or psychologists available to them. And what they can do is if the OBGYN is detecting there's something going on with the patient, there's a phone number they can call, and they're provided with consultation with a perinatal psychiatrist who can help the OBGYN direct patients in the right place in terms of getting support, therapy, as well as give them recommendations for how to prescribe medication for those patients. Project Teach, which is here in New York, is also doing very similar kinds of work, and it provides consultation with reproductive psychiatrists, as well as trainings and educational programs. Postpartum Support International, which I mentioned before, which is an amazing organization. And as the name implies, it is international, but there is a huge presence in the US, and every state really has their own, I believe, has their own chapter, but certainly in the tri-state area, they really have a huge presence, and they provide a confidential hotline, and then there's lots and lots of free groups. So if you've never been on their website, I encourage you to look around, and each week and every day, there are a variety of groups. There's ones that are for very specific communities. There are ones that are really for the broader postpartum parent community. And it can be a wonderful resource for people, because this can be a time when people are feeling quite isolated and may have a hard time talking about how they're feeling with people close to them. And this can be an opportunity to get support from other new parents. The US Health and Human Services Department, Health Resources and Service Administration, HRSA has launched a maternal mental health hotline, which a lot of people have been providing for their patients. And there's also the National Curriculum for Reproductive Psychiatry, which is sort of working on the accessibility issue from a different angle, from the education perspective. And this is an amazing curriculum that you can also find online. It was spearheaded by Lauren Osborne, who is a perinatal psychiatrist, and a lot of her colleagues. And it was designed to teach reproductive psychiatry to mental health professionals through either educational workshops or a self-guided program. And it's really designed to be able to be incorporated into resident education, provided in graduate school education, so that people who are becoming mental health professionals really have the opportunity to study sort of the state-of-the-art research and care models in reproductive psychiatry. So that's really been a game changer and such important work in terms of improving accessibility for the treatment of PMADs. Now, I think the treatment of PMADs is really important, but there are so many negative effects of postpartum depression. And even if someone only remains depressed for, let's say, the first few months or the first year, the negative effects of that period of time, given that it's such a sensitive time for infant and child development, they continue and continue. So prevention of postpartum depression is essential. And it's really been my work, both as a researcher, a developer of a prevention intervention, and as a clinical psychologist. I've really been focused on how do we identify people at risk, and how do we provide them with services so we can prevent the symptoms of postpartum depression, or at least mitigate them, so that if postpartum depression occurs, we're able to detect it earlier and treat it as quickly as possible. So the U.S. Preventive Services Task Force has come up with a list. You can look it up online of interventions that they endorse. And I'm going to talk about 3 of them today. The first 2 I'm going to talk about, it'll be rather brief, but I want to give you a bit of an introduction. And then I'm going to provide you with a QR code that you take a picture for yourself or link yourself to the website so that you can really get as much information as you would want. Unfortunately, in a webinar, I don't have time to kind of go in super in depth into each one of them, but I would love to give you a brief introduction to the ROSE program, which stands for Reach Out, Stay Strong Essentials, and also the Mothers and Babies program. And then after I introduce you to those two interventions, I'm going to really provide an in-depth look at the PREPP intervention, which stands for Practical Resources for Effective Postpartum Parenting. So first, we'll focus on the Mothers and Babies program. So this is an intervention that is evidence-based and is aimed at preventing postpartum depression and alleviating stress during the perinatal period. It utilizes psychoeducation through 3 modules. First, the pleasant modes of thought. Second, effective utilization of social support. 3, engagement in pleasant activities. This intervention is delivered via self-directed workbook and by trained facilitators. They have a one-on-one modality, and that's delivered over the course of 9 20-minute sessions. And this intervention can also be provided in a group format and delivered in 6 90-minute sessions with 2 booster postpartum sessions. And this specific intervention is rooted in cognitive behavioral theory as well as attachment theory. And it has been shown to be effective in preventing postpartum depression. As mentioned earlier, it's recommended by the U.S. Preventive Services Task Force, and they have been able to show significant changes in postpartum depression and anxiety at 6 months postpartum. So we'll now just turn to the next page, and here's the QR code. So take a picture of it or scan it for yourself and link yourself there if you'd like to learn some more information about mothers and babies. It's really a wonderful intervention that's provided in a lot of different contexts. All right. Moving on to the ROSE program. So ROSE, as I mentioned before, stands for Reach Out, Stay Strong Essentials for New Moms. It's an evidence-based practice for reducing cases of postpartum depression among low-income and racially and ethnically diverse birthing parents. Now, this intervention is offered as 4 or 8 90-minute sessions during pregnancy and 1 50-minute postpartum booster session. And this intervention is based primarily on IPT principles. So that's interpersonal therapy principles. And these sessions involve psychoeducation on postpartum depression, information about managing the transition to motherhood, managing relationships, self-care, engaging in assertiveness and goal setting. And then there's also a review session. Nurses, health educators, and others with or without mental health expertise have been shown that they can successfully provide ROSE, and this is offered both in English and in Spanish. And ROSE prevents half of postpartum depression cases among low-income parents. And again, as I mentioned, it's a U.S. Preventive Task Force recommendation. And so I'll go to the next page and give you the QR code so that if you're interested in getting more information and learning more, it'll be provided there. Great. So now, the next point of focus is an intervention that Catherine Monk and I developed, and we've been collecting data on for well over a decade now, and it's called the PREPP intervention. And again, PREPP stands for Practical Resources for Effective Postpartum Parenting. It begins during pregnancy, and PREPP is really focused on taking a dyadic approach. So the intervention is based on the conceptualization of postpartum depression as a potential disorder of the dyad. So while for many interventions, we're really focused on specifically the mood disorder and the symptoms that exist in the parent and treating those, we're really interested in working with both the birthing parent and the infant as we've thought about creating this intervention. So we think about postpartum depression as a potential disorder of the dyad, and one that can be approached through preventive psychological and behavioral changes in the birthing parent that affect both the birthing parent and the child, even before birth. So when we think about the parent-infant dyad, we really need to think about a unique bidirectional relationship that exists between them. And this really goes back to those risk factors we were talking before, right? If difficult infant temperament is a risk factor for postpartum depression, we really need to be thinking about sort of how we can work with both the parent and the infant in terms of making a situation where people are less likely to develop postpartum depression. We know that challenging behaviors in infants, such as fussing and crying, lead to increased levels of stress, depression, and anxiety in parents. And there's been lots of studies. We have 2 cited here, but many studies that show that relationship. We also know that there are behavioral techniques that are effective in changing infant fuss and cry behavior and infant sleep behavior. So PREPP is really focused on taking these 2 areas of research to inform our intervention model. So the first area of research that we're interested in is infant behavior has an effect on the mood, affect of parents. We also know that there are certain behavioral techniques that can help babies to sleep more and to cry less. And so that data is really important for us when we were developing this research model. Also important to us was that PREPP would be designed to be accessible. We wanted it to be low cost and efficient. We wanted it to be able to be provided by lots of different kinds of providers. And we have trained many people. We've trained, of course, psychologists, psychiatrists, clinical social workers, but we've also trained labor and delivery nurses, nurse practitioners, community mental health providers, and other doulas and other people who are really working with this population. We wanted to design it to be an alternative to psychiatric medication when possible. We also designed it to reduce stigma. So we call our therapists in this program coaches, and we're really presenting this as a parenting coaching model versus a strict psychotherapy model. We designed it to be very few sessions in conjunction with routine medical appointments. So in our pre-COVID days, we were offering them at the exact same time. So you come in, let's say for your ultrasound, and then immediately after you could meet with your PREPP coach for one of the sessions. Now we provide them online, and that also adds a level of convenience as well. So it can be done in either way, really in conjunction with routine medical appointments or at people's convenience via Zoom therapy. So I mentioned before it was brief. It's quite brief. There's 5 sessions, 3 full sessions, and then 2 shorter sessions. They start between 28 and 32 weeks gestation, and we finish at 6 weeks postpartum. And they're designed to treat those people who are at risk for postpartum depression. So people who have current stress or depressive symptoms, people who have a history of mood disorders, people who have other challenges in the postpartum period, and those people who are experiencing serious challenges related to socioeconomic status. So on these next few slides, I'm going to give you an introduction to what this intervention looks like, and what is in each of our sessions. So for session 1, as I mentioned, we're starting between 28 and 32 weeks. So we're right there, sort of in the beginning of the 3rd trimester. Again, this can be provided in a private practice, in a clinic, in a virtual setting, and it's 45 to 60 minutes. We have done lots of intervention studies and provided it kind of in conjunction with medical care. And we also, our mental health division that we have here in our Department of Obstetrics and Gynecology is a co-located mental health division. So we're able to provide it in conjunction also with people's regular medical appointments. The focus of this first session is we call harnessing a dyadic focus. We really want to get a sense of where people are psychologically in terms of thinking about themselves and the fetus and the relationship that's developed between the 2 of them. We want to work hard to establish an alliance because, of course, in such few sessions, it's really important that we have a strong treatment alliance with participants in the PREPP program. We also want to encourage a self-reflection practice. We ask people questions about their own childhoods, things that happened in their childhoods that they really look back on very fondly, parenting practices that their parents used that they thought were good, as well as things that were not ideal, and ways in which their parents behaved that maybe they felt like were not good for them as they look back on that as adults. And what we're trying to do is help people to reflect on their experiences as a child, to start to create intentions for what kind of parent they want to be. We also teach them about basic sleep hygiene and some sleep skills, and we teach them how to use mindfulness, both to help manage feeling overwhelmed in moments when they're feeling distressed, as well as to improve the quality of their sleep. And particularly, we talk to people about using this when you wake up in the middle of the night, when when you have to go to the bathroom while you're pregnant, and then you go back to sleep and you just can't get your mind to stop thinking about all the things you need to do, or maybe worries that you're having. We teach people to use a mindfulness practice to help them fall back to sleep more easily and quiet their mind. And then as part of this session, we provide people with an app that we developed that has meditations on it. And we can also provide them with mindfulness audio files if that's easier for them. And we also give them an information sheet that gives them information about basic sleep hygiene and things they may want to start practicing now, because as we all know, in the third trimester, sleep gets to be much more challenging. The second session happens near the end of the third trimester. And again, this can happen in the clinic or it can happen virtually on Zoom. It's also a 45 to 60-minute session. And in this session, we're reviewing all the prior skills we've learned. We're following up on any challenges they were experiencing this time. We're getting a sense of who are the support people in their lives. We're really trying to help them psychologically prepare for the baby being here. And we're also providing them with psychoeducation. And I'll go into more detail about what that involves. About what to expect in the early postpartum period. And we also teach them some basic infant caregiving techniques that have been shown to help babies to sleep more and to cry less. And then as part of this session, we provide them with a PREPP pamphlet. This can be done. We have a glossy version of the pamphlet, like a paper pamphlet, and then we also have it in digital form that can be downloaded on their phone. And what's great about this pamphlet is that it summarizes all the information that we provided them with in session 2. So they don't need to hold it all in their mind. They have been introduced to it and they have easy access to it, either on their phone or in a paper form, whatever they're comfortable with. The third session is a much briefer session, about 15 to 20 minutes. It's really kind of a check-in. And we contact someone a few days after giving birth. And we talk to them about how their delivery went, and we also review the PREPP pamphlet for specific techniques and information that they're going to need in the first 2 weeks postpartum. We talk about swaddling with them, we talk about carrying, we talk about using mindfulness to fall back asleep after you get up in the middle of the night to feed the baby. We also talk about using mindfulness to help people to feel less distressed in moments that are challenging. And we let them know that we're going to be in touch with them again for another check-in 2 to 3 weeks postpartum. So at this point, typically people are kind of settling into a routine. They're starting to figure out feeding a little bit more. Perhaps they're getting a better sense of the rhythm of feeding and sleeping with the baby. And we check in to see how that's going and also to offer possible suggestions or work through in terms of problem solving. We assess the use of the techniques that we've taught them. Have they been swaddling? Has the mindfulness been helpful to them? Are they able to carry their baby in the way that we described in the intervention? And of course, all of the techniques that we teach, we talk about them as a toolbox that the parent uses as they see fit. So it's not an intervention where they're required to use any of the skills we teach them, but rather they're the expert on their baby, they're the expert on their situation, and we're just giving them more techniques that can make this a little bit easier and a little bit more manageable. We really want to be receptive to understanding the challenges that they're experiencing in newborn care. And then the last time that we meet with them, and this is another full session. So the full sessions are session 1 and session 2, which take place during pregnancy. And then our final session is a full session, 45 to 60 minutes. Again, it can be offered in person or virtually. And we have them practice self-reflection about this transition to parenthood, how things are going, how has being a parent to this baby for the past 6 weeks changed them. What are they thinking about in terms of the challenges of this period? We assess the use of the techniques. We encourage them to use techniques that might be helpful in managing some of their current challenges. And if there's some things, sometimes people forget how to use some of them, or they have questions about them. And this is really an opportunity to review the techniques where necessary. Each PREPP session is comprised of a series of components. And so I'll go through each one of the components, but they're really a part of each one of the 5 sessions that I just outlined. And the first one is assessment and psychodynamic interviewing. And of course, this takes up the most time in the first session, because what we're trying to do is ask people questions so we know who we're working with and we can most efficiently present this information to them, while also building an alliance and also making it feel very personal to their circumstances. We found the best way to get people to use these techniques is to help them think through how they would use them in their specific circumstances. We also want to build the therapeutic alliance, and we do so by asking a lot of different kinds of questions, which are meant to both help them set intentions for what kind of parent they want to be, as well as to help them feel better understood by the PREPP coach. So we gather lots of information during the session, and we're really aimed at promoting reflective functioning and getting the parent to be really focused on this developing parent-infant dyad that is on the way. We also provide participants in the PREPP program with psychoeducation, and we do that to limit negative attributions of both the self and the infant. So, for example, we talk about what happens to your hormones in the postpartum period. Oftentimes, people are quite surprised by how much their hormones increase, particularly by the end of the 3rd trimester, and that within only a few days postpartum, they've dropped back down to their pre-pregnancy levels. This hormonal shift can cause a lot of feelings of being overwhelmed, more tearful, and for someone who tends towards negative self-attribution, this can make them think about themselves. I never should have become a parent. I'm completely overwhelmed. I'm not ready to do this. We teach them also about the period of purple crying, and I'm going to get a bit into that in a bit, but this is what to expect from your baby in terms of crying. And I think this really helps limit both negative self-attributions of the parent, like my baby's crying because I'm not doing a good job. We want to challenge that idea because crying is a normal part of child development. We also want to limit the negative attributions that are put towards the infant in terms of I have a bad baby, for example. We want to really help people know what to expect from crying. Similarly, we also want to really help people understand what to expect in terms of infant sleep. It seems like babies sleep all the time, so it should be easy for you to sleep. But of course, babies are sleeping in 2 to 3 hour chunks in the beginning. And of course, that level of interrupted sleep is really disruptive. And because sleep is so closely associated with mental health and mental health symptoms, it's really important for people to understand the challenges that they're going to have to their sleep and help strategize with them ways to help them to get more sleep during this period. So I want to focus a little bit on the period of purple crying, because I think this is such a wonderful psychoeducation tool that can be provided to parents during this period so they know what to expect. The period of purple crying, it refers to the period starting around 2 weeks and then kind of moving into the 2nd and 3rd month of a baby's life. And this is when the baby is going to cry more than any other time in their life. And if you're a person who tends to be more anxious or a person who tends to blame yourself for things, what could happen is you bring a baby home, they're not crying that much those first couple of weeks, but then they begin to cry a little bit more each and every week. And oftentimes parents can blame themselves that they're not doing a good job. They had this baby and they were doing great, and now they're crying all the time, and it's because I'm not a good parent. Or it's because there's some serious medical problem, the doctor can't find it. The crying is so activating. And so it's really good to have this kind of psychoeducation about this normal developmental period, which Ron Barr coined the period of purple crying. And you can see the website here. I encourage you to look at it. It's a bit of an older website, but the information is really great. So P stands for peak of crying. The baby cries more each week and the most in month 2, and then less in months 3 through 5. U stands for unexpected. So crying can come and go, and you don't know why. R is resist soothing. So no matter what you try, your baby may not stop crying. And I think it's great for parents to know that sometimes just holding and rocking your baby, even if it's not immediately solving the problem, that's okay. You're there and you're experiencing this moment of distress with your baby, and that can be enough. You don't always have to solve it. P is pain-like face. A crying baby may look like they're in pain even when they're not. L is long-lasting. Crying can last as much as 5 hours a day or even more. E is evening. Your baby may cry more in the late afternoon and evening. Oftentimes people call this the witching hour. But what's important here when we think about the period of purple crying is that it's a period of time. There is a beginning and there is an end. And I think it's really great to be able to let parents know, wow, this is such a hard time and it's coming and it's going to be challenging, but it's not going to last forever. We just need to get through this kind of challenging period for a couple of months. In addition to providing the psychoeducation, we also provide the PREPP behavioral techniques. And so here I have the list of all the specific behavioral techniques that we teach parents to help reduce cry and increase nocturnal sleep. So we teach people about focal feeding. We teach people about the accentuation of day and night cues. So specifically when it's daytime, we keep the lights on, we don't use blackout shades, and babies sleep with background noise and things like that. And then at nighttime, we make it feel very different. We make the room really dark. If we have to speak, we do it very quietly. And it's not a time for playing or singing or those kinds of behaviors. And then in so doing, we're kind of sending the message to the baby, the daytime is the time we're awake and we're engaging, and the nighttime is the time when we're quiet. And this is a way to really begin to try to shift more of the baby's sleep during the nighttime. We also engage in other attentive activities other than feeding when babies first get up so that we can try to extend the nighttime feeding intervals. We encourage people to carry their infants at least 3 hours a day, independent of when we're feeding the baby or when we're comforting the baby when they're crying. This has been shown to reduce crying in babies. We also teach people how to swaddle. People in our intervention get a swaddling blanket, and we teach them how to use it as a way to help babies to sleep longer and also to comfort babies when they're crying. We also teach, as I mentioned, mindfulness exercises, both to manage distress in really difficult moments, as well as to improve sleep, specifically how to fall asleep faster. On this diagram here, this is sort of how we're thinking about PREPP working. So we can enter really at any point. So let's talk about helping babies become better behaviorally regulated. So we do that by teaching parents how to use these behavioral skills. The parents use these behavioral skills with their babies, and babies become more regulated. The baby's more regulated, this improves the parent's sleep and lessens their level of distress. The baby being more regulated also helps the parent feel more self-efficacious and more confident in their parenting, and this confidence in their parenting really helps them feel less distressed. We also use the psychoeducation tools to help people feel more confident and lessen their distress, and the mindfulness tools also designed to lessen distress. I mentioned that we like to provide tools to people, and the first tool that we provide is a specialized meditation app that we developed specifically for PREPP. We wrote 3 meditations. The first meditation here is a mindful walk, and that is something that can be done both while someone is pregnant as well as when the baby's born, pushing the stroller, carrying the baby in a baby carrier, and it's just an opportunity to have sort of an emotional reset. We also have a mindful moment for when you don't have a lot of time. It's a 2.5-minute meditation just to use as a reset. And this is really useful, I think, particularly in the postpartum period, during the period of purple cry in particular, when people are feeling super overwhelmed. We encourage people to put their baby in a safe place like the bassinet. And if they're feeling overwhelmed, and go to the bathroom, close the door, find a private space for themselves, and take 2 minutes to use this to help lessen their distress level. And then we also modified progressive muscle relaxation for use with people during pregnancy and the postpartum period. This is about a 7 or 8 minute exercise. We really encourage people to use it anytime, but particularly when you're falling asleep. It helps quiet the mind. It helps move your mind away from things that you're feeling anxious or worried about, or things that you're upset about. It helps to relax your body and helps you to drift off to sleep more easily. This is really useful during pregnancy, as I mentioned before, when you're getting up to go to the bathroom in the middle of the night. And it's also really great in the postpartum period when you're frequently waking up at night to feed the baby and you may need some help falling back asleep. One of the big challenges that comes up when working with postpartum parents is I feed the baby, I finally get the baby back to sleep, and then I only have, an hour and a half left to sleep, and then I spend 45 minutes trying to fall asleep. Getting practice at falling to sleep with this with this meditation can really help cut down the amount of time it takes to fall back asleep. And here's the pamphlet that I referred to earlier. What you can see is we present it as a program that's designed to help people with the challenges of being a parent to a newborn baby. And we detail a lot of the challenges, and we try to normalize some of the really difficult moments that parents have in the early postpartum. We talk again specifically about hormones. And as you can see here, we really show them this is what's happening in those first few days postpartum. And wow, that can feel like a lot and can be really overwhelming. We also teach people what the symptoms of the baby blues are and also the symptoms of postpartum depression. And what's great about PrEP is that for people who begin to start to experiencing these symptoms, there's someone who's meeting with them regularly, has eyes on them. And if we feel like things are not going in a good direction, this can be a great opportunity to get them into a more intensive treatment. And you're doing it much earlier than you normally would, thereby really potentially having great effects for both the person experiencing the symptoms as well as the family and the baby. As I said, we discuss with them the period of purple crying and give them information about that. We also provide them with some really basic skills about what to do when your baby's crying. You need to comfort them. These are things that are super common sense, but I think it's really nice to sometimes have them written down in one place when you're feeling so sleep deprived and so tired. It's great to just be like, oh yeah, okay, I checked the baby's hungry, tired, or has a wet diaper. Okay, that's taken care of. What else can I do? Okay, I could go for a walk. I could sing to the baby. I could do skin to skin contact, etc. We also have a diagram here for how to swaddle and safety techniques to be thinking about when you're swaddling. We also teach people how to use a carrier. As I said before, we encourage people to use a carrier or carry their baby just in their arms an additional 3 hours a day when they're not feeding the baby or comforting the baby while they're crying. And we talk to them about the benefits of using an infant carrier. And one of the things that's really nice about it is it can really free your hands to do other things. And babies enjoy being in them oftentimes. And we also teach people how to safely use a carrier. So if you have someone in the PrEP program, we ask them to bring their carrier with them to the session if they have one, so that we can practice together. We also talk about the importance of day and night cues as a way to help baby get on to a better schedule with sleeping more at night and a bit less during the day. We also talk about specific feeding techniques that you can use to help your baby to get more nocturnal sleep. And these tools are started 2 to 3 weeks after the baby's born and only after the baby is healthy, gaining the right amount of weight, and you get the okay for the pediatrician. And then again, we talk about mindfulness and we give them just a written description to remind them of how mindfulness can be helpful to them. And then on the back of our either digital pamphlet or actual paper hard copy pamphlet, we give them some information of some things that they may want to bring with them to the hospital. So now in our, the remainder of our time together, I want to focus a little bit on the data that we've collected on this intervention. So for the studies that I'm going to be reviewing today, The people who were recruited to be in this study were pregnant people ages 18 to 45, and they were enrolled based on being at risk for postpartum depression. And they were assigned to either PrEP treatment or the enhanced treatment as usual group. The enhanced treatment as usual group is a group that met with a clinical psychologist several times during pregnancy and then postpartum. They received evaluation and referral to the community for mental health care if it was requested by the participant, or if the research participant was deemed to be necessary by the mental health provider. We measured maternal mood before they started the study, and then throughout the study and at the end of the treatment. And you can see we use 2 blind clinician rating measurements. So we use the Hamilton rating of depression and the Hamilton anxiety rating scale. And then we also use self-report measures like the PHQ-9, which is really commonly used in medical practice, and of course the Edinburgh postnatal depression scale, which is used very often in research on postpartum depression. We also measured infant fussing and crying and sleep behavior using the baby day diary, which is a well-validated measure developed by Ronald Barr, who we spoke about a bit earlier with the period of purple crying. So I'll be discussing this efficacy data for this first clinical trial that we did on PrEP. And in this study, we had 58% of the participants were Latinx, 19% were Black. The age was 18 to 45 years old with an average age of 30 years. And all of the participants in this research study qualified to be in the study because they were determined to be at risk for postpartum depression based on the predictive index of postnatal depression. And this is a questionnaire that's administered and with lots of risk factors for postpartum depression. So if you endorse a certain number of them, then you're determined to be at risk for postpartum depression. And at baseline, before receiving any treatment or being assigned to either the PrEP group or the ETAU group, people were on average having a mild to moderate level of depression. And there was no significant difference between the 2 groups. And we had an average of about 16 on the Hamilton depression, indicating a mild to moderate level of depression before they entered into the PrEP study. In terms of adherence in this study, we actually had 100% of participants who were assigned to PrEP complete all sessions in the intervention. And here is a very busy slide with the results of our linear mixed effects models. We really just need to focus at the bottom here. And what we're seeing is a difference between the groups. So right here, our first red circle indicates that we had a significant difference at 6 weeks in depression scores between those people who were in PrEP and those people who were in our ETAU study. We saw the same thing for anxiety. We saw the same thing on the endorsement of symptoms on the PHQ-9. At 10 weeks, we saw that we had a trend towards significance for depression and anxiety, and then we saw a difference between the 2 groups in the anxiety level of parents in PrEP versus those that were in ETAU. And I think these results are better seen in these change scores. And so what you're seeing is the change in the depression scores over time. And these are the clinician ratings of the participants. And so what you're seeing is that in the enhanced treatment as usual group, we see an increase in the depression scores. And in the PrEP group, we actually, from pregnancy to postpartum, saw a decrease in those symptoms. And that decrease continued over time. We also see for anxiety, a significant difference between the enhanced treatment as usual group and the PrEP group, with the PrEP group becoming less anxious over time. And we also see the same thing with the PHQ-9 here at 6 weeks, where we see a sharper increase in the endorsement of symptoms versus those in the PrEP group. We also saw a difference in infant fussing and crying behavior, with babies in the PrEP group showing an average number of episodes of fussing and crying at a lower level than those in the enhanced treatment as usual group. In the next study, whose data I want to present, This was a study of participants who were specifically selected for being at risk for postpartum depression because they were living at the poverty level or a bit above. Poverty, as I mentioned earlier, and low SES is a significant risk factor for postpartum depression. So the eligibility criteria for this second study was the salary self-reported to be at the standardized level of what's called near poor struggling. And this is sort of the income criteria for Medicaid. So as mentioned before, poverty is a huge risk factor, not surprisingly, for postpartum depression. And low SES is associated with increased depressive symptoms late in pregnancy and at 2 to 3 months postpartum. In this study that I'm detailing here, you see that women with 4 SES risk factors, specifically low monthly income, less than college education, unmarried, unemployed, unstable housing, were 11 times more likely than women with no SES risk factors to have clinically elevated depression scores at 3 months. And subjective SES endorsed people who endorsed low SES, that was significantly associated with major depression at 6 months postpartum. So in this study, we recruited people who were at risk for postpartum depression based on their income level. And what we see here is we had 84% of the people enrolled were Latinx. We had 18 to 45 years old was the age range, with 28 years being the average. They all met the SES criteria of being at near poor struggling, and they qualified for the income criteria for Medicaid. All of the participants had Medicaid insurance. In this population, different than the earlier, we had the depressive symptoms at baseline were relatively low. So we didn't have a psychiatric clinical sample that we had in the earlier study. Instead, we had a group that was sort of scoring lower on the EPDS, and we had slightly lower adherence in this group. So we had 100% completed in the first, which was really quite remarkable. We had 83 here, which is still, for an intervention study, a really great adherence rate. And what you're seeing here on these diagrams, again, is a replication of the results. So we see that the people who are in the PrEP group had lower levels of anxiety at 6 weeks, lower levels of depression at 6 weeks, and lower levels on the EPDS endorsement at 6 weeks at a significant level. And we also saw a significant result in terms of the amount of sleep babies were getting. Those in the PrEP group getting more minutes of sleep at 6 weeks versus those in the ATAU group. And for crying, we didn't have a significant result, but more of a trend where we're seeing fewer minutes of crying for the babies in PrEP versus those in ETAU. So we also saw, we administered the Bailey, and we saw a significant difference between the Bailey adaptation score for those babies that whose parents received PrEP versus those in the ETAU group. So what are some clinical conclusions from this data? Well, first, we found that PrEP is a feasible clinical protocol, and we've been using it in our own clinical service at Columbia, in our embedded service in OBGYN now for years, and it really is a feasible clinical protocol that has high acceptability and people are really interested in participating in. We've had low to no dropout for our PrEP sessions, and we've been able to successfully show that PrEP reduces symptoms of depression and anxiety in birthing parents at risk for postpartum depression. PrEP may even have an effect on infant behavior, as we showed in those data that we presented on infant crying behavior and infant sleep behavior. And we also think that our data really indicate that when we're thinking about prevention of postpartum depression, we can't just think about the parent who gave birth and only treating them. We really need to think about their entire circumstances, and we really need to think about the parent-infant dyad, right? Postpartum depression affects the entire family. And I think it's really important to be thinking about the ways in which we can be helping people to have better interactions with their infant, feel better about themselves as parents, and improve the quality of the interactions of the parent-infant dyad. I think that, both of these studies show that PrEP has a positive effect for parents at risk for postpartum depression. And what's great about that is PrEP can increase accessibility to PPD preventive treatment. First, because it's few sessions. So we don't need, for many people, obviously for patients who have much more severe mental illness, severe bipolar disorder, psychosis, those people need a lot more than what PrEP has to offer. Although we do believe PrEP can be helpful to all patients, but it's not enough for everyone. So I think it's something that can be really useful to use for a patient who needs more comprehensive care. It can be a piece of the treatment. And for some people, it's all the treatment that they need, and it can really help change the trajectory of their postpartum so that they are experiencing a postpartum with fewer symptoms of depression and anxiety. I think it's also great to think about offering programs that work on mental health that are not specifically billed as mental health services. I think people can be very motivated to engage in parenting courses during this time and doing things for the baby, and to be able to have something that focuses on them becoming a better parent, but also helping them with their own mood is really important. It's great that this is so few sessions and can be provided by a lot of different kinds of providers, because it really allows it to be low cost and more easily integrated into other kinds of services. PrEP, along with the ROSE program and the Mothers and Babies program, are really wonderful programs that are effective, evidence-based preventive measures for postpartum depression. And what's wonderful about having more accessibility to these kinds of programs is that we can avoid this 2-generational lasting impact of leaving postpartum depression untreated. Prevention is so essential, and the more focus we can have in our clinical practices on preventing postpartum depression, the better. Accessible prevention will not only improve parents' lives, but also the lives of future generations. If you're interested in getting PrEP trained, I'm going to leave this up for just a second, and I'll talk a little bit about the PrEP training in our few remaining minutes that we have left, just to give you a sense if this might be something that you'd be interested in or good for your service. I do think that the lessons of PrEP, in terms of focusing on the dyad, in terms of really improving access to people's understanding of what to expect in the postpartum period, those can be integrated into lots of kinds of psychotherapies. But if you're interested in getting the full PrEP training, you can scan here and be led to our website to get some more information. Our trainings are straightforward. They're tailored to the intended clinical population. We've worked with people in hospital settings, in group home settings, for adolescent pregnant people. We try to customize our trainees' experience to what training they've had before and really help them to understand this period and how best to use these sorts of psychoeducation and behavioral skills with the people that they're working with. We do our trainings 100% virtual, and they require 8 hours of training and then a 1-hour certification assessment. So in terms of trainings, it's not a super long course of training. And as I mentioned before, we have trainees from a lot of different clinical backgrounds: clinical psychologists, psychiatrists, occupational therapists, social workers, case managers, community health workers, nurse practitioners, and students from all different disciplines. And we've trained people, first started training people in the US, and now we're training people all over the world. We've been doing a lot of work in Australia, which has been really amazing. They have a very different model over there and a lot more support in the postpartum period. But this has also been a great addition for them. So that's been wonderful. Again, here's in case you missed it the first time, here's the QR code for the training. And if you're interested in learning more about the work that we're doing at Perinatal Pathways, so that is the laboratory of Dr. Catherine Monk, and I'm the Director of Clinical Intervention Research there. We'd love to hear from you. There's my email. Love to hear from you about work that you're doing. We have different kinds of studies. So clinical intervention work is one of the things that we do, but we've been doing work for a long time and really understanding the perinatal pathways through which the experience of the parent during pregnancy is transmitted to the fetus and how it affects infant and child development. I would love to thank all of our sponsors for our research. So from National Institute of Mental Health, the Robin Hood Foundation, who provided us with the funding for the study of PrEP with people who are of low SES, Selene Institute, NIH, Child Health and Human Development, Bezos Family Foundation, the Nathaniel Wharton Fund. We really appreciate their support so much in this work that we're doing. And I'd really like to thank these three people here who helped me with pulling these slides together. First is Madeline, who is getting her PhD in clinical psychology, and Lauren and Kat, who are both Barnard students in the SRI program, that's a Summer Research Institute, who were really super helpful in pulling these slides together. So that is the end of my presentation. And I would love to answer questions that people might have and talk more about this. Evelyn,
I got it. Thank you. Sorry. Thank you so much. This was such a rich and informative presentation. And a lot of questions were really about how to get training, how to access services, and also all of the QR codes. Everybody wants them. So we'll make sure that in the follow-up that we send out all the resources with it.
Sure.
So one of the questions asked was, how do you involve non-birthing parents?
So it's definitely, we personalize it depending on the specific family. And what's going on with them. So usually our first session, we're meeting just with the birthing parent, but the second session where we are really focusing on psychoeducation and the skills building is a wonderful time to involve non-birthing parents as well as other support people. We've learned so much in that first session about who this person is, who are people that matter in their life. And so getting people involved in that second session is really great and really can set up a family for being more successful in the postpartum period, because we want people to know what to expect in terms, if you forget that the first 3 days after you give birth, your hormones go through this huge shift and you may be feeling super overwhelmed. It's great if somebody else can say, hey, listen, don't be so hard on yourself. Remember, you've just gone through this huge event and your hormones have shifted in this way, and that can have a really big impact on how you're feeling. So getting people on the same page is really important. Also, I think getting people on the same page about carrying babies, swaddling, and those kinds of behaviors where people can not, if we all are presented with the same information, it's easier for families to be on the same page about those kinds of things. Also crying. And why I think crying is so important to talk about is oftentimes if you have a non-birthing parent home with you, it's for a couple of weeks. And then all of a sudden they're at work all day, and the time they come home, all that's happening is the baby is crying the entire time that they're awake when this person is home. It can be quite jarring and worrying and upsetting. And it's wonderful to have this information that this is a normal developmental period. This is the trajectory. This is what it looks like. And these are some skills for how to get through it.
Great, thank you. So somebody just posted the question, wondering if, and I also wanted to say that the PowerPoint, the recording will be posted on our website in a few days. So everybody's asking about that. And I guess one of the biggest questions is if people want to refer somebody, what are the resources out there, who's trained, how can people figure out where to send people? They're very enthused about this intervention and trying to find out how to connect families that they may be working with this training.
Yeah, so Columbia we have clinicians trained both in our ambulatory care clinics. So those are the clinics that primarily accept Medicaid insurance. So we have a variety of providers who are trained in the intervention, and then also through our service here at Columbia, which is for patients who are OBGYN patients. They have access to get this as part of their OBGYN care. And then we've been training people all, kind of progressively all over the city. We have some more coming up and all around the world. So you can reach out to us. I gave you my email, and then there's also, if you link to the training QR code, you can get some more information, and we can, if there's a place near you that we have PrEP trained clinicians, we can try to connect you. We have a whole sort of directory.
Terrific. Okay. Somebody questioned whether if the PrEP intervention has been initiated in the early postpartum period, for example, in the pediatric practice, possibly aligning with newborn visits, or would it be less effective at that point?
So we have a sort of modified manual for when it's not possible, because of course people deliver early, there's all different kinds of things. So we do have a manual to how to address those modifications. In terms of our clinical trials, we've studied it delivering the information during pregnancy. And why we like that is because we feel like we're providing families with this whole set of tools that they can use in the postpartum. And when you introduce them in the postpartum, there's a lot going on. The baby's already here. There's a little less sort of psychological room, but it definitely has been done, and it can be done. We just don't have data on that because that's not how the intervention was originally designed. But something that would be really interesting, and I think that's something that we could potentially think about. Time is always a challenge in terms of engaging people. Those first few weeks postpartum, which is really when we're aiming to use the tools of the intervention to make a difference and change the trajectory in terms of parental mood, we're really are really busy. There's a lot of appointments and there's a lot going on, and there's not a lot of sleep. And so that's why we decided to start during pregnancy.
Terrific. Have you done any research about how PrEP is different for first-time parents versus parents with older children? And how does PrEP look different, if at all, for mothers of older children?
It's interesting. So I will be introducing psychoeducation skills, for example, and we'll talk about like the period of purple crying, and people will say, oh, my first one never did that. I don't think this baby will do that. And oftentimes, or they'll say, oh my gosh, my first baby cried so much, it was so difficult. And so I think it's totally unique. It depends on the person. I think there's also this sort of protective thing that happens that we don't exactly remember how hard it is to take care of a baby during the first couple of months, and how challenging emotionally it is. And so I think sometimes people don't always remember the challenges. So I think it depends on the person. But sometimes they'll say, wow, I'm so glad I had this. I had totally forgotten about X, Y, and Z, and I wish I had this with my first baby. But I noticed that it's pretty personal to who I'm working with in terms of how having a child before affects their reception in terms of the PrEP skills.
So somebody also wondered about how this was culturally adapted for different populations and what your experience has been around that.
Yeah, so yes, a lot of the people in our research study are Latinx. That's the population that we work with in Washington Heights in New York. But we are also delivering the intervention in our other practices, and so we've had a really kind of wide variety of people who are using it. And interestingly, when I work with people internationally, there are so many different ideas about some of the skills. So sometimes we do some adaptations. So I really try to personalize the treatment with who are you working with, what matters to them, who are these people, and then we think about how do we adjust and make some slight modifications to PrEP. So for example, I was working with a psychiatrist in Italy. They do not use swaddling, apparently, in Italy. And I'm just working with another clinical psychologist in Italy, and it's something that's really not part of their practice in terms of what people are doing at home with their babies. So we had to change that, because if it doesn't make cultural sense to the people you're working with, then there's no point in including it. So that was removed for the Italian version of PrEP. In other interventions, what's kind of wonderful is there's more visiting nurse practices in Australia. And so we really thought about PrEP in a different way, that if you can teach this to the visiting nurse, they're coming into the home and they're able to work on those skills right in the home environment. So those were some of the changes that we had to do for our Australian partners.
Great. Somebody asked, how can we get fathers, families involved with information about postpartum depression? Yeah,
I think that in terms of specifically in PrEP, the second session is a wonderful opportunity to do that. And I think providing families in the perinatal period, like in medical appointments, I think having a more standardized approach to giving people information and sharing that with families. Oftentimes people go to birthing classes together, or they will go to an infant care class together. And I think that those kinds of will be great opportunities to provide non-birthing parents information about perinatal depression. But frankly, I think that it's something that both the people who are pregnant and postpartum and the partners who are not, there's sort of a paucity of access to information. I mean, it's online, but I don't think people necessarily know the places to go. And I think also, with anything online, there's often challenges around vetting what gets posted, what matters, these different chat rooms and things like that. I think there can sometimes be information that's not accurate or useful. So getting really high quality information to people in the context of, obstetrical and postpartum care, I think is really important.
Absolutely. And, there's been so much interest in this, and I did want to let people know we will post the PowerPoint. I think that what's really important is that people have the access to go back to get the information. You post a lot of QR codes, whatever. The PowerPoint will be online, so people can get that I also want to ask Ian if you could just post the evaluation in the chat box so people could fill that out. Somebody wanted to know the question about whether you've adapted this for teen parents, whether you see any differences in working with teen parents.
Yeah, that is one of our sort of next, so we've done it with teen parents, but we haven't collected data and done a specific RCT with teen parents, but I think that is a wonderful area. And I'd also like to think about it with people who are more severely mentally ill and who are of higher need, and how you would incorporate that into regular psychiatric care, because I think there are a lot of skills here that would be useful to a lot of different kinds of psychiatric patients. And this would be certainly not enough care, but it would be a really wonderful adjunctive piece to a more traditional, psychotherapy treatment.
Well, first of all, I want to say that the feedback survey was posted in the chat box. I really encourage people to fill it out. It really gives us feedback in terms of planning for future trainings. I think this was a wonderful webinar, and I think it's whet everybody's appetite to learn more, and a lot of questions about how to get to the resources, how to really kind of follow up, where can you refer families. So I think this is a beginning discussion, and one that's just so critical and important. So I want to thank you. Thank you for your expertise here. This was really incredibly informative and such an important topic. So please, people, before you sign off, please do go and fill out the feedback form. It's very important to us to really kind of get your input in terms of the trainings that we've done and how to really shape further trainings going forward. So thank you, everybody, and it's been a pleasure. Thank you, Dr. Werner.
Yeah, my absolute pleasure, and looking forward to hearing from everybody. And thank you so much for tuning in. I really appreciate it.
Thank you.